Assalamu alaikum and good evening to you all. Welcome to the Masterclass on OSPE for MBBS Final Year Student episode nong 6, organized by SCP Bangladesh Chapter and supported by Bangladesh Society of Medicine. As you already know, it is a program which is designed for the medicine OSPE or final professional MBBS examination. Today's topic is the most interesting topic of the OSPE examination. Yes, today's topic will be the pictorial part in the OSPE. We all know identifying the object in the picture is the most important part in the OSPE examination. To teach us about the pictorial given in the OSPE examination, we have a legendary professor here with us. Among the students, he is known as the favorite professor of all time. Yes, he is none other than Professor Muhammad Zakir Hossain sir. He is the Professor of Medicine, TMSS Medical College. He is also the founder chairperson of Hypertension and Research Center, Rangpur. Today's program will be chaired by another legendary professor, a true leader, and the governor-elect of SCP Bangladesh Chapter, Professor Khan Abul Kalam Azad sir. He is also the former president of Bangladesh Society of Medicine. As a panelist, we have another renowned professor of medicine, Professor A.K.M. Aminul sir. He is the chairman, financial committee of SCP Bangladesh Chapter and vice president of Bangladesh Society of Medicine. As a moderator with us, we have Dr. Muhammad Moniruzzaman Asraf sir. He is the assistant professor of medicine, Shahid Ziaur Rahman Medical College, Bogura. During the live session, you can ask topic-related questions in the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Muhammad Moniruzzaman Asraf sir. Dr. Muhammad Moniruzzaman Asraf sir.
Thank you, Dr. Prince Kawser, for conducting the sessions. As far as you know, the OSPE is the important examinations of the final profession as well as the undergraduate and as well as the postgraduate examination. In corona pandemic situations, our study, our lessons, our class will be held. So in situation, ACP Bangladesh chapter is a good initiative for the final professional student for the important examinations preparations. I like to thanks our at first Professor H.M. Nazmuhasan sir, thanks for this initiative, and this final profs OSPE Pictorial is a chairperson Professor A.K.M. Professor Khan Abul Azad sir is a governor elect designee and ACP Bangladesh chapter and former president of Bangladesh Society of Medicine. Panelist Professor A.K.M. Aminul sir, chairman financial committee ACP Bangladesh chapter and vice president Bangladesh Society of Medicine. And speaker Professor Zakir sir, professor of medicine and ex-principal and ex-head of Surgery Medical College and now TMSS Medical College and founder chairperson Hypertension and Research Center Rangpur. আমি একটু ইংলিশ বাংলা মিক্সচারে বলবো যে এখন অসপি পরীক্ষা এবং অসপি কোশ্চেন এবং অসপি পার্টটা খুবই ইম্পর্টেন্ট এবং আমি সত্যি আমি ধন্যবাদ জানাই স্যারদেরকে এবং এসিপি কে যে তারা একটা এই প্যান্ডেমিক সিচুয়েশনে একটা ভয়ার্থ পরিবেশে ছাত্রকে হেল্প করার জন্য সারা বাংলাদেশের পঞ্চম বর্ষের ছাত্র যারা পরীক্ষা দেবেন যারা পরীক্ষা দিচ্ছেন এটা খুবই হেল্পফুল, এটা খুবই একটা গুড ইনিশিয়েটিভ। আমি আবারও স্যারদেরকে এবং এসিপি এবং যারা সাপোর্ট করছে সোসাইটি অফ মেডিসিনকে ধন্যবাদ জানাই। নাও আই রিকোয়েস্ট our speaker, our the legend professor, the important parts of the OSPE is a pictorial diagnosis for the OSPE examination. I request Professor Muhammad Zakir Hossain sir, Professor of Medicine, TMSS Medical College, former principal and former head of Surgery Medical College, and founder chairperson Hypertension Research Center. আমি স্যারকে তার প্রেজেন্টেশন দেওয়ার জন্য অনুরোধ করছি। স্যার প্লিজ, প্রফেসর জাকির হোসেন স্যার।
Thank you, Dr. Moniruzzaman Asraf, for introducing me. Thank you, Dr. Prince Kawser, for organizing this program. I am very much glad and thankful to President SCP Bangladesh Chapter, Professor H.M. Nazmul sir, my direct teacher. When I was a student, third year, just after passing first Prof examination in the year 1982, my first ward was medicine ward. And Professor Nazmul sir, at that time, registered medicine in the ward number, the number 1, Dhaka Medical College Hospital. So I am very much lucky enough to be a student of Professor Nazmul sir, and today he is here, and he is the President, ACP Chapter Bangladesh. Thank you, sir. Thank you, today's Chairperson, Professor Khan Abul Kalam Azad, my senior respected colleagues, brother and teacher, and he is the future Governor, ACP Chapter Bangladesh. Today's discussion, panelist, Professor A.K.M. Aminul, Vice Chairman, Bangladesh Society of Medicine. Today's topic, OSPE discussion. OSPE is an important tool of examination both for undergraduate as well as postgraduate student. And pictorial part or OSPE in clinical medicine is very important way of learning. Many of the rare disorders which are not encountered in day-to-day practice, we can get idea about those conditions by seeing the picture. For juniors, it is not possible to see all the cases. They can take the idea of those not seen yet. Today's presentation for 5th year MBBS student, those who are appearing in 5th year final examination. And I am discussing some common picture taken from textbook. I think definitely this will help to the 5th year examining students. My first station number 1. You are seeing a picture of part of hand. And question is, study the photograph and answer the following question. In this picture, there are 4 questions and their number distribution 2, 1, 1, and 1, that is 5. In the 5th year examination, OSPE, that is total number of OSPE is 50, and there will be a 10 station. Each station carrying 5 marks. Then first question is, describe the image. And what is the most likely name of the lesion? Write down 1 investigation for confirmation and write down 2 drugs for treatment. Next stage, describe the lesion. Yes, you have seen there is a swelling in the distal part of the finger, among irregular swelling with whitish discoloration. So, image shows irregular swelling with whitish discoloration, some nodularity at some seen at margins with deformed in distal interphalangeal joint. It also shows thinning of the nail. Next question, what is the most likely name of the lesion? You all know, most likely it is topaz. So it is topaz, or it may be any solid swelling with infection. But likely in this picture, first we consider it is topaz. Next question, write 1 investigation for confirmation. And topaz is an important clinical sign for gout. And in gout, confirmatory test is aspiration from the lesion shows monosodium urate monohydrate crystals. Write down 2 drugs for treatment. Hossain, allopurinol, febuxostat, and probenecid. So any 2 can be written in the examination. Now, this is very simple picture, simple question, and simple answer. Next station. Look at the picture and answer the following. Write down the positive finding of this image. Number 2. Name 2 investigations, 1.5, and write down 2 drugs in this condition, 1.5. Now the description. Image shows protruded eye, that is exophthalmos, tibial swelling in both eyes, lid retraction, and anxious look. So, by inspection, we can say about this. Next, to investigation for confirmation. Obviously, this picture likely of thyrotoxicosis. So, the investigations will be thyroid hormone study, FT34, FT4, PSAs. Another investigation may be thyroid ultrasonography with radioiodine uptake test and scan. So, by uptake test, hypo and hyper can be differentiated. By hormone estimation, we can confirm it. Next question, write down 2 drugs in this condition. You all know carbimazole, the choice of drug. Sometimes we can use propyl thyroid if carbimazole is contraindicated. Another station number 3. This gentleman having a swelling in the left axilla in the anterior fold. This is the finding. Next, let's say, write down 4 underlying cause. That is, this sort of swelling, likely nodular swelling, likely lymph node, and mention investigations. Now, we are seeing answer. A swelling in the left axilla. Next, underlying cause are most likely tuberculosis, lymphoma, leukemia, or sarcoidosis, secondaries. Now, the investigations are, in this condition, any swelling, any lymphadenopathy, first choice of investigation is complete blood count, yes sir, and a comment on peripheral blood. Chest X-ray view, FNAC, biopsy. So, these are the investigation of choice in delineating this lesion, to find out the cause of this lesion, to find out the etiology of the lesion, or to find out the diagnosis. By this investigation, it is possible to reach a diagnosis. Question number 4, look at the face. There is deviation of angle of the mouth to the left with opening of the right eye and loss of wrinkling in the right side of the forehead. So, this is the description. Describe the finding. Angle of the mouth is deviated to the left with loss of nasolabial fold in the right, loss of wrinkling of the right side of the forehead with opening of the right eye. Whether this is upper or lower motor neuron lesion. Obviously, it is lower motor type lesion in the right side because wrinkling absent, eye is open, and nasolabial fold is absent in the right side. So, lesion probably in the right side and lower motor type. Now is lower motor neuron lesion. Into treatment options. Yes, you all know probably this is Bell's palsy. Bell's palsy etiology is idiopathic sometimes, or there may be underlying viral cause. So treatment is antiviral with steroid and physiotherapy. So antiviral with steroid along with physiotherapy. In this particular case, physiotherapy plays most important role in the management of Bell's palsy. Next, station number 5. Look at the face. See the photograph of the face and answer the following questions. Mention 2 important findings in this image. Then what is your diagnosis? And mention 2 drugs. Now, look at the picture. There is some nodular lesion throughout whole face with thickening of the skin, with thickening of the ear lobules. So, we are now see the description. Widespread nodule with thickened skin, loss of eyebrow, thickened ear lobule. Then what is diagnosis? It is obvious. You all know. This is a case of leprosy. Next, 2 drugs inhibiting this drug. You all know the choice of drugs: rifampicin, dapsone, clofazimine. So these are the drugs used in the treatment of leprosy. Now come to the station number 6. Look at the face. Findings in this particular figure, in the face, in the left side of the forehead, there is vesicular lesion with crust formation and involving the left eye also, and the lesion not crossing the midline. Very characteristic, the lesion not crossing the midline. Now, and what is the diagnosis? We all know this is likely herpes zoster infection. Write down 2 important groups of drugs used here. As it is viral infection, you all know antiviral drugs. We prescribe it. It sometimes decreases the period of illness, that is, length of illness take কমায় দিচ্ছে. কিন্তু actual this sort of lesion usually after a few days of disease process may be secondarily infected. In that case, broad spectrum antibiotic may be needed along with antihistamine. Broad spectrum antibiotic and antiviral treatment is sufficient to cure the patient. Again, this patient usually shows the usually present with severe pain, itching. In that case, analgesics, antihistamine, amitriptyline, pregabalin may be helpful. Station number 7. A young boy, 12 years old, presented with history of progressive weight gain. He denied any history of drug intake and identified as hypertensive. That is, young boy, 12 years old, obese with hypertension. Mention 2 important observations. And what is the most likely diagnosis? Observation. Number 1 observation is he is obese. Definitely he is obese. And there is prominent stria in the abdomen, in the chest. Prominent stria. Also, some stria present in the limbs also, upper limb. What is the most likely diagnosis? Yes, it is Cushing syndrome. Most likely. Karan, Cushing syndrome is an important cause of secondary hypertension. Now, how will you confirm your diagnosis? Right. Serum cortisol. Another important test is dexamethasone suppression test and 24 hours urinary free cortisol. In case of dexamethasone suppression test, after giving dexamethasone, cortisol level will not decrease, rather it remains high. Another important investigation is brain imaging, that is CT or MRI of the brain. Sometimes there may be pituitary adenoma behind these findings. So brain imaging is an important investigation in this particular case. Next picture. In the back, in the dorsal aspect of the forearm, there is lesion. Now, scaly erythematous rash over the extensor surface of the forearm. Circumscribed clean cut margin with scaly lesion. Silvery scale is present at some places. Yes, what is the diagnosis? This is obvious. This is obvious, not fungal infection. Obvious, not eczematous lesion. This is psoriasis. Name 2 drugs which may exacerbate this condition: systemic steroids and beta blockers AC inhibitors, sometimes exacerbate the clinical finding or clinical course of the disease. Station number 9 is a very common picture, very interesting. Young lady, look at the face. There is erythematous butterfly rashes. And what is the most probable diagnosis? You see, butterfly malarial rash. So most likely diagnosis is rheumatological disorder, that is autoimmune condition, SLE, systemic lupus erythematosus. And write down the investigation of this condition. Clean cut. Complete blood count, 24 unit total protein, autoantibody, that is ANA and anti-dsDNA. So from history, from clinical finding, and by some few investigation, we can sure about that it is SLE. Station number 10. A 20-year-old boy presented with fever for 3 months. Look, fever for 3 months, that is prolonged fever. Pictorial examination revealed persistent murmur. Study of the photograph, and so 20 years boy, 3 months fever with a murmur in the chest, precordium. And the positive findings are in this picture: and thinning of the nail and splinter hemorrhage. Most likely diagnosis is, considering all the scenario, all the findings, that is 3 months fever, precordial murmur with splinter hemorrhage. Likely it is infective endocarditis. Now, how will you confirm the diagnosis? Yes, blood culture, and blood culture the most important one. Another is echocardiogram, that is to find out to see that is there any vegetation in the valves. So, infective endocarditis is an important clinical condition, though not so common at this moment in our country due to lack of decreased prevalence or incidence of valvular lesion due to decreased prevalence or incidence of rheumatic heart disease. This picture, a 30-year-old man presented painful lesion in both lower limbs, which is not ulcerated. That is, in his legs, in the anterior aspect, in the shin, there is redness, and there is a patient complaining about pain, and on palpation, it is very much tender. So, this is likely erythema nodosum. What are the predisposing factors of this condition? Maybe bacterial infection, that is streptococci, mycobacteria, or mycoplasma. Maybe viral, that is hepatitis B virus, or infectious mononucleosis may give rise to this sort of lesion. If this patient has history of cough and joint pain, chest X-ray bilateral hilar shadow, what may be the diagnosis? Yes, it is very obvious. That is cough, joint pain, among bilateral hilar lymphadenopathy. So, likely diagnosis is sarcoidosis, and in sarcoidosis there may be erythema nodosum. So, if a patient came to us with this sort of lesion, a first inspection we can say about erythema nodosum. Then we have to search about the cause of erythema nodosum, and by considering history and other clinical finding, we can easily make the diagnosis. A 12-year-old boy presented with respiratory distress with sinuses. Young boy having breathlessness, having sinuses, and picture shows there is clubbing. So, clubbing, sinuses in a young boy. Likely, some congenital disorder may present in this condition, and most likely congenital condition which may cause sinuses, clubbing, as well as breathlessness in a young boy is congenital cyanotic heart disease. So in this picture I'm showing, write down the name abnormality. That is clubbing. That is clubbing. Write two bedside test for confirmation of clubbing are: number one is fluctuation test, another is window test. Fluctuation test will be positive. In window test, there will be no gap in between two nails. Most likely cause are cyanotic heart disease, that is tetralogy of Fallot or PDAVSD with reverse shunt. Likely, in this particular case, tetralogy of Fallot is the most likely answer. Look at the lower limbs of this patient. You see, right lower limb, that is leg and foot, is swollen. So write down two differential diagnoses of this image. Number one, DVT, deep venous thrombosis, or there may be cellulitis. Though there will be there is no redness, but cellulitis may be the possibility. Mention three relevant investigations. The relevant investigation for confirming DVT is duplex study of the lower limb vessels. Again, we can do D-dimer test and complete blood count, by which, if it is cellulitis, there will be polymorph leukocytosis. Now, what are the drugs used in this condition? Number anticoagulant warfarin, rivaroxaban, low molecular weight heparin, or unfractionated heparin. So, if a patient presented this sort of finding, that is swelling, unilateral leg swelling, most likely DVT. Another possibility not discussed here may be a case of filariasis. So filariasis is also, but nowadays it is uncommon due to widespread use of antiviral drugs prophylactically. Say, look at the young boy. There is maculopapular rash throughout whole body, involving trunk, limbs, even face, neck, etc. Maculopapular rash. Maculopapular rash. Write down two differentials. Yes, most likely it is measles. Maybe dengue fever. It may be a case of bleeding disorder, such as leukemia or aplastic anemia. But drug cause most unlikely. Then 4 investigations: complete blood count with peripheral blood film, NS1 antigen, dengue antibody, movement examination, and RT-PCR. So with all these, we can establish or exclude the differentials and confirm the clinical diagnosis. Station 15. Look at the face. You all see there is a with slight elevation in and around the eyes. Likely it is central, the lipid deposition in the subcutaneous space. Most likely underlying causes hypercholesterolemia. What are the advice you will provide to the patient? The advice is a lifestyle advice. That is lifestyle modification, dietary advice, exercise. And if there is very much increased lipid pattern, then specific anti-lipid agents should be addressed. Here, tongue is raw, beefy, and angle of the mouth is reddish, and there is ulceration. And this is a common picture found in deficiency state. What sort of deficiency? It is glossitis and angular stomatitis. Yes, likely diagnosis is iron deficiency anemia. So iron deficiency anemia may give rise to this sort of pictures. Now, the investigations are blood count, comment on peripheral blood film, and iron profile estimation. In case of blood count will be normal. There will be MCV will be definitely decreased, MCA is also decreased, percentage saturation will be increased, and in peripheral blood film there will be microcytic hypochromic anemia. So patient came to us with glossitis, with angular stomatitis, and if there is microcytic hypochromic anemia, it is nothing but it is iron deficiency anemia. So investigations are complete blood count with PBF and iron profile. Look at the hand. The fingers of the right hand probably that is deformed. Joints are solid. Metacarpophalangeal joint, interphalangeal joints, and wrist joint also solid and deformed. Definitely, it is rheumatological disorder because disorder affecting the joints and musculoskeletal system. There is swan neck deformity, that is in the index finger, you see the pattern of involvement of the joints gives the appearance of swan neck. Yes, likely it is rheumatoid arthritis. In the rheumatology, the most important disorder is rheumatoid arthritis. It is an autoimmune disorder, maybe seropositive, maybe seronegative. Other disorders in the rheumatological disease are cerebral spondyloarthropathy or SLE or MCTD or PSSS. No one gives rise to such pictures. So any patient, particularly female patient, if presented with this sort of hands, think about it is nothing but rheumatoid arthritis. And rheumatoid arthritis diagnosis mostly clinical. Lab investigation will help to confirm the diagnosis. So if we found this sort of hand in clinical practice, it is nothing but it is a case of rheumatoid arthritis. Now the investigation for these patients are ESR, CRP, rheumatoid factor, and anti-CCP antibody. I think this will be positive, or ESR will be raised, CRP will be positive, RA factor may be positive, or sometimes may be negative. Anti-CCP antibody usually positive because the sensitivity and specificity of RF, that is rheumatoid factor, around 70%. But anti-CCP antibody sensitivity and specificity, it is above 90%. So it is most important investigation in confirming rheumatoid arthritis. Look at the abdomen. You see the wall of the abdomen contains veins, prominent veins, engorged vein, and this is more marked around the umbilicus or above the umbilicus. So abdomen is distended, umbilicus probably flat, engorged vein, and it is more marked in and around umbilicus. So likely it is caput medusae, that is engorged vein in and around umbilicus, that is form umbilicus, some radiating structures, some structures radiating center to periphery. And this is probably portal hypertension due to cirrhosis of liver. Now, how will we confirm this condition? Number one, ultrasonography of the abdomen, liver function test, aesthetic fluid study, and viral markers. Yes, in ultrasonography, we make it liver is small, shrinkage, and there are nodularity, fibrosis, etc. LFT will be altered. Aesthetic fluid study shows transudatory fluid, and most important cause of cirrhosis of liver in our country till today, sequelae of chronic hepatitis, viral hepatitis, that is B virus and C virus infection and sequelae হিসেবে most important, that is complication, that is cirrhosis of liver or chronic hepatitis or cirrhosis of liver. So the most important cause is viral infection. But for confirmation of cirrhosis of liver biopsy is must. But nowadays it is infrequently done. From history, from clinical examination, and some supportive investigation, we can share about it is a case of cirrhosis of liver. So usually liver biopsy not needed. Yes, another investigation, endoscopy of apology to see the presence of esophageal varices, and it is present in about 60% of portal hypertension patient having cirrhosis, underlying cause. If cirrhosis of liver, around 60% of this group of patient shows esophageal varices. Now, if suddenly patient developed drowsiness, name 2 factors which aggravate the condition. Yes, if paracentesis is done in this condition, patient may suddenly develop hepatic precoma, or if electrolyte imbalance, particularly hypokalemia, or if the patient having secondary infection, spontaneous bacterial peritonitis, or any other infection, patient may develop drowsiness, that is hepatic precoma, and ultimately may turn into hepatic coma. Look at the picture. Young person, young patient. Patient try to stand herself and taking help on his limbs, that is pressing upper limb, hands over the knees, and after taking help from the knee, that is climbing, she is trying to stand up. That is, and there is the calf muscle, that is hypertrophy of the calf muscle, probably pseudo-hypertrophy. So she is trying to stand up by taking help on herself, by placing hands over the knee and thigh. At the same time, leg muscle shows hypertrophy. It is yes, CPK, muscle biopsy, or EMG may help in reaching diagnosis. Sometimes genetic study is helpful. Another picture, look at the picture, right lower limb. This patient having ulcer in the sole, and this ulcer definitely is a chronic ulcer, clean cut margin, and this patient you see having polyuria. At the same time, there is blurring of vision. So, patient having polyuria, this polyuria may be due to chronic kidney disease, or may be due to diabetes mellitus, or may be due to any other reason, as for example, patient taking diuretics. But patient also having blurring of vision. at this age, 50 years old person having blurry vision. Study the photograph and answer the following. So it may be a case of neuropathic ulcer. Patient probably may have diabetes that gives rise to polyuria and blurring of vision. So there may be diabetic neuropathy. There is loss of sensation of the right foot, and there is an ulcer, that is chronic ulcer in the right foot. So diabetes mellitus with diabetic foot, it's a neuropathic ulcer. Now, write down 6 investigations for this patient. At first, we have to confirm whether patient is diabetic or not. We can confirm it from history. If we ask the patient, what are your problems? Whether you are diabetic or not, whether you are hypertensive or not. From history, we can share about whether he is diabetic or not. If his patient is not non-diabetic, in that case, we can do fasting, blood sugar, and 2 hours after 75 grams of glucose. And if fasting more than 7 millimole per liter and 2 hours after 75 grams of glucose more than 11.1 millimole per liter, then sure he is diabetic. At the same time, we have to do his kidney status, his hemoglobin, etc., his ECG, etc., because long-standing diabetes may give rise to many micro as well as macrovascular complications. Among the macrovascular complications are neuropathy, nephropathy, and retinopathy. And among macrovascular complications, that is stroke or TIA, ischemic heart disease, or peripheral vascular disease. So, by searching all these points in the history and during clinical examination, we can share about whether has been suffering from diabetes mellitus, whether any complication present or not, or whether other comorbidities present or not. So, investigations are complete blood count, RBS, A1C, lipid profile, urinary, serum creatinine, electrolytes, and other investigation may be needed depending on the presentation. So, this sort of picture in an adult or elderly person, most likely neuropathic ulcer, and most important cause in our country is diabetes mellitus. Thank you. Thank you all. So, I am discussing some common pictures taken from some textbooks or common textbooks, Davidson, Kumar and Clark, and Hossain, McLeod. These are commonly asked in the examination, and undergraduate student definitely will get some information, and that may help in their upcoming examination, final examination. I am giving thanks to SCP Chapter Bangladesh for giving me the chance to say something about pictorial teaching for undergraduate student. Thank you, sir.
Thank you so much, sir, for your amazing presentation. I can see the comment section flooded with questions. Now it's time for the question and answer session. I sincerely apologize first because we won't be able to answer all the questions because the time is short, but we'll try to answer as much as possible. To start the question and answer session, let me hand over the session to Dr. Muhammad Moniruzzaman Asraf, sir. Dr. Muhammad Moniruzzaman Asraf, sir.
শোনা যাচ্ছে? কথা শোনা যাচ্ছে? হ্যালো, থ্যাংক ইউ স্যার, শুনতে পাচ্ছেন স্যার?
Yes, sir, you're audible, sir. Yes, sir.
আচ্ছা, thank you, Professor Dr. Zakir Hossain, sir. It's a nice presentation and elaborately and chewable and palatable, maybe for the student. কারণ OSPE খুব একটা ইম্পর্টেন্ট সেশনস, কারণ পরীক্ষা হলে এটা খুব তাড়াতাড়ি ছাত্রদেরকে ক্যাপচার করতে হয়। অর্থাৎ ছাত্রদের কাছে আমি বলবো, আমি ইন অ্যাডিশন সারা লিডেন প্রফেসর সবাই আছেন, যে প্রশ্নের ভিতরেই কিন্তু অনেক উত্তর এবং ক্লু, যে পিকচারটা দেখে তার সাথে প্রশ্নটা তারা যদি সমন্বয় করে, তাহলে চট করে তারা পিকচারটা তারা ধরতে পারবে এবং কেউ অনুযায়ী অ্যান্সার দিতে পারবে। এই জন্য প্রশ্নটা খুব ভালোভাবে করতে হবে। It's very much important. আমরা যেটি যে কন্ডাক্টিং প্রিন্স কাউসার বলেছেন যে অনেক স্যার অনেক অনেক কমেন্ট আসছে, কমেন্টে ভরা। এখানে দুইটা কোশ্চেন স্যার আসছে, আমি বলতে চাচ্ছি যে একটা কোশ্চেন যেটা আসছে স্যার হচ্ছে, আমি যে স্পিকারকে বলতে চাই, প্রশ্নটা হচ্ছে যে হোয়াট আর দ্য রোল অফ বিটা ব্লকার অ্যান্ড এসি ইনহিবিটর ইন সোরিয়াসিস পেশেন্ট? What are the role of beta blocker and AC inhibitor in psoriasis patients? Sir, please answer this question.
Thank you, Dr. Ashraf. Beta blocker, it is seen the beta blocker and AC inhibitor, if we prescribe in psoriatic patient, it sometimes may exacerbate the symptoms of psoriasis. That is, skin lesion may be aggravated. So, in psoriatic patient, it should not be prescribed.
আমি প্রফেসর একে আমিনুল স্যারকে একটু অ্যাড করার জন্য বলছি যে স্যার যদি কিছু অ্যাড করেন স্যার এই কোশ্চেন অ্যান্সারে, যেটা আপনি প্যানেলিস্ট স্যার প্রফেসর আমিনুল স্যার। স্যার শোনা যাচ্ছে না
স্যার? প্লিজ আনমিউট ফার্স্ট স্যার।
স্যারের কথা
স্যার,
শোনা
ইউ হ্যাভ
যাচ্ছে না।
টু আনমিউট ফার্স্ট স্যার। No sir, you're still not unmuted sir.
স্যার আপনার কথা শোনা যাচ্ছে না স্যার।
Sir, you have to click the unmute button once sir. Yes sir, yes sir, yes. Yes, yes sir, yes.
Thank you. Actually, psoriasis, it is an autoimmune disease, and we see that many factors can affect this, and one of the factors are drugs. So when simultaneously with other drugs, if we prescribe either beta blocker or AC inhibitor, and Professor Zakir said properly that it increases the symptoms, or it psoriasis is a remission and exacerbation type of disease. So after taking these drugs, the symptoms or the lesions may exaggerate. For this reason, these two drugs should not be used. Thank you.
Thank you, sir. The valuable opinion regarding the questions. And another questions, why wrinkling of the forehead is preserved in upper motor neuron lesion of the facial palsy? Sir, Zakir sir, please. Another questions from the audience or from the students. Why wrinkling of the forehead is preserved in upper motor neuron lesion of the facial palsy?
Hello. Network problem.
স্যার শুনতে পাচ্ছেন স্যার? জাকির স্যারের হচ্ছে যে নেটওয়ার্ক
Deviated to the left. Angle is deviated to the left. Angle deviated to the left. Left eye a bit closed. In the left side, wrinkling is present. In the right side, wrinkling absent. Eye open. Angle of the mouth in the right side is dropping. There is dropping. So in the right side of the face is complete paralysis. That is paralysis of the right facial nerve. So it is most likely lower motor neuron lesion. In case of lower motor neuron lesion, the most important cause in our country is Bell's palsy. So as all branches of the facial nerve are affected, so from top to bottom, that is forehead, eye muscle, buccal muscle, labial muscle, and platysma, all will be paralyzed. So in the right side of the face, all action will be absent. In the left side, all will be present. And unopposed action of the left side of muscle, angle is deviated to the left.
Thank you, sir.
Can you hear me, Dr. Ashraf?
Yes, sir. Yes, sir. So thank you for answering these questions. I mean, our panelist,
Network problem.
Professor Aminul, sir, please add anything more about this question.
Actually, this is properly answered. Nothing
sir.
To add about the answer of this question. Thank you.
Thank you, sir. স্যার ম্যাক্সিমাম এই আর তেমন স্যার হচ্ছে যে কোশ্চেন তো স্যার হচ্ছে যে কমেন্ট বক্সে স্যার শুধুমাত্র খালি কমেন্টে ভর্তি স্যার। আমরা কি স্যার আপনি
আমার মনে হয় শেষ করে দাও।
জি স্যার, জি স্যার। তা এখন আমি স্যার প্যানেলিস্ট প্রফেসর আমিনুল স্যারকে কিছু বলার জন্য স্যার অনুরোধ করছি যে অসপি সম্পর্কে, কিভাবে অসপি তারা চর্চা করবে, পরীক্ষা হলে কিভাবে তারা অসপি ফেস করবে, এসব টুকিটাকি স্যার দেওয়ার জন্য স্যার হচ্ছে যে অনুরোধ করছি স্যার। এবং কিছু এবং আজকের এই সেশন সম্পর্কে স্যার আপনাকে বলার জন্য অনুরোধ করছি স্যার। প্রফেসর A.K. Moniruzzaman স্যার, প্যানেলিস্ট for this session.
Thank you, Dr. Asraf. Actually, nowadays, OSPE is part of both undergraduate and postgraduate examination. And students are also habituated to this OSPE examination. Examination includes not only picture, but also data interpretation and also problem solving items. So, pictorial questions are part of the OSPE examinations, and many rare cases may not be seen in the patient, but I suggest the students, if they want, try to see the pictures in the patient. If they see these lesions in the patient, they can remember more and they can answer it properly, because these lesions are highlighted in the pictorial question, but this patient have other comorbidities, or if the students can talk with the patient, they can learn also many other things. And because of this background, they will be more confident and they can answer the questions properly. If the students take this preparation throughout the year, only then they can answer the questions properly in the exam. And students should remember that the OSPE is a separate section, and he or she should pass the OSPE questions separately. So it is very important, and it takes a major part in their preparation. So I advise the students to prepare themselves properly so that they can answer the questions. And another thing is, when they read the question, if they have an idea in their mind that it may be such, only then they can answer the question. Otherwise, if their guess is wrong, the whole question may be wrong and the answer will be wrong. So the guess of the question or the problem by reading the question is very important, and it is only dependent on the background knowledge of the student. So I ask them to prepare themselves throughout the year so that they can do good in the examination. I thank the speaker, Professor Dr. Zakir Hossain. He is a renowned professor of medicine, and I think he elaborately and very soundly addressed these pictorial questions. And I also thank the SCP chapter governor to arrange this sorts of learning session for the student who will be the future eminent doctor in our country and who will take the responsibility to treat these whole nations. I thank the arranger and I thank the speaker. Thank you.
Thank you, Professor A.K. Aminul sir, for the nice informative message toward the students for helpful the preparing the upcoming OSPE examination in the professional exam. Now I want to request our liaison professor, those are engaged in undergraduate and postgraduate examination. আজাদ স্যার, যিনি আন্ডারগ্রাজুয়েটে অনেক পরীক্ষা নিয়েছেন, প্রশ্ন করেছেন, পোস্ট গ্রাজুয়েশন উনি পরীক্ষা নিচ্ছেন এবং অনেক কোশ্চেনের সঙ্গে উনি সংযুক্ত। স্যারের যে বিশাল অভিজ্ঞতা, সেই অভিজ্ঞতার আলোকে আমি স্যারকে রিকোয়েস্ট করবো রিগার্ডিং দ্য সেশন এবং OSPE সম্পর্কে আন্ডারগ্রেজুয়েট স্টুডেন্টরা কিভাবে প্রিপারেশন নিবে, কিভাবে এই বিশদ ওভারঅল ইনফরমেশন দেওয়ার জন্য আমি স্যারকে রিকোয়েস্ট করছি প্রফেসর খান আবুল কালাম আজাদ, প্লিজ স্যার। এক্স প্রেসিডেন্ট of Medicine, ex-principal Dhaka Medical College, and recent councillor of the Bangladesh College of Physicians and Surgeons. Sir, please, sir.
Thank you. First of all, the beginning was done by Dr. Prince Kawser. Thank you very much, Dr. Prince Kawser. So fluently you begin the program. So it gives a very good flavor to the whole program. Thank you again. And also to introduce everybody is again another very difficult task, but you made it very easy. And then the anchor of the session, the moderator, a very good teacher, very, you know, I know him, Dr. Moniruzzaman Asraf, since his studentship. And I know how much he is capable to learn, and also his, you know, the quest for learning was so enormous. And still I remember him when he was a student in 5th year class, and also he was a student post-graduation, he was a trainee doctor. And so I think that he's becoming a very good teacher in the future. And it was a very good composition, what Dr. Moniruzzaman Asraf made to make a very good moderation. And to talk about the panelist, Professor Aminul, he is a very renowned senior teacher. He is teaching the students since a very long time, and I know him. And he is a very kind man, very good soul, and also a very keen person to learn. Still he is learning. Professor Aminul as a panelist, I'd like to give him thanks because he was in the session. And also you see the speaker of the session, a great teacher, Professor Zakir Hossain, who makes, you know, very difficult things very easy. And he is a very simple man, walks very simply, talks very simply, smiles all the time. He has got no confusion, and the things, the 20 photographs, and the students can get an idea that the photographs which have been selected here, the 20 photographs, I was looking at each and every one, starting from gouty to fast, then exophthalmos, axillary lymph node, 7 palsy, leprometer space, arpit zoster, ophthalmicus, then Cushing syndrome, and so on, so on, so on. And he began like this one, and he continued, and he ended with your Duchenne muscular dystrophy and diabetic foot ulcer. So what an important message he threw to the students, that from every chapter, every part of your book, a photograph can be made. Some questions can be made from that photograph. So a very difficult thing, that how to make a good photograph, how to make some questions, how to make very simple answers, and then marks distribution. It was so wonderful. I like to congratulate Professor Zakir Hussain. Sitting with him really is an honor and privilege, with such a teacher who made this topic so excellent. And it's because, you know, it's not only for the undergraduate students, it's also for the postgraduate students, and also for every practitioner doctor who will be practicing medicine in his future career. He got some messages from the photographs. So it was very amazing, and also a very good learning session for me, that from every topic he can make a photograph, he can make some questions. So for the student, whenever you study a chapter, well, from every chapter, you just see the photographs which are given in the book. You go through the 3 or 4 books, and you find out the photographs which are shown in the photos. So those are the things which are very important. He didn't bring your complicated X-rays, he didn't bring the CT scan photographs or something like that. But the thing is that photographs can be composed of so many things. It was so wonderful, and really I was very privileged and to be a part of this session. And there were two questions, those were answered very properly. The thing is that exacerbation of psoriasis, there are many factors by which the psoriasis can be exacerbated, and there may be a spontaneous regression of the disease for the time being, and then exacerbation. There may be a seasonal variation of your psoriatic exacerbation. Two of the drugs have been mentioned, the beta blockers and ARBs. But there are so many other drugs like lithium, quinine, NSAIDs, infliximab, antibiotics. All this can exacerbate psoriatic lesions. So that is a very good question, and the teachers answered properly. And second question was that why there is no involvement of the upper muscles in upper motor neuron lesions. So you see, the question is that, and in the nucleus of the seventh nerve is in the pons, and it has got a connection with the upper cortical fibers. So each side of the cortical fibers, they give fibers to both the nuclei. So one nucleus in the pons of seventh nerve, they get the connection or the corticonuclear fibers from both the cortices. So right-sided cerebral cortex gives fiber to the right seventh nerve and also to the left seventh nerve. So the left one is giving the same thing to the left seventh nerve and the right seventh nerve. So when one corticonuclear fiber from one cortex is interrupted or disrupted or cut, you see the other cortical fibers, the corticonuclear fibers, are supplying the nucleus as the upper motor neuron. So it is the supranuclear fibers. So when these supranuclear fibers from the other part is working, then you see that there is a sparing of the upper part of the face, which is supplied by these fibers mostly. But it was beautifully explained by Prof. Zakir Hossain. So when all the five ramifications of the facial nerve, when they are involved, that over the parotid gland in the lower motor neuron, so usually the lesion is in the stylomastoid foramen or in the facial canal. So you can see these five nerves are five branches. The five ramifications are disturbed, and so you can see the complete paralysis of unilateral face. So that same side. So ipsilateral complete facial paralysis, it is the lower motor neuron. And contralateral lower half paralysis, it is the upper motor neuron lesion. So that is the thing, is the mechanism by which you can see the difference in corticonuclear fiber innervation in each of the seven nerve nucleus in the pons. So these were a beautiful two questions, and the teachers, the way they answered, they talked, and everything was so wonderful. And definitely, if I could be a student of 50th now, it could be a very important for my exam. And also, I got an idea to make the photographs in future for the students, which will help them to learn and then to apply in their practical life. So finally, you see the SCP chapter and Bangladesh Society of Medicine. What a tremendous job. Every day when I attend this meeting, I learn so many things. So it's a learning session. I like to give thanks to our dreamer, Professor H.M. Nazmullah, our present, His Excellency, Mr. Governor. Because, Mr. Governor is such a teacher, who is not only a teacher at this moment. He is teaching the undergraduate students, postgraduate students, but he is a teacher of the teachers. So he knows how to give the best to the students. Thank you, Professor H.M. Nazmullah sir, for your extraordinary effort to help your students. So it's a father, it's not only a teacher, it's a father to teach their students that my students should learn everything. And another important part is that he's involving the teachers from the whole country in the process to teach. So this platform has become a unique platform for bringing every teacher from any part of the country. I hope this will be continuing, and our teachers will come here. They will teach their students, And for this, this SCP and Society of Medicine both can be congratulated. At the same time, that COVID has given us the opportunity, this opportunity, that we can sit in front of our you see the monitor, then we can attend the classes. So thank you very much, Professor Nazmullah-san, for everything. This SCP chapter and Bangladesh Society of Medicine is giving the full support to this meeting. Again, thank you very much for Bangladesh Society of Medicine. And finally, I like to give thanks to the participants. I know the huge number of participants are there, and I also read their, the comments, the diagnosis they immediately they made when Professor Zakir was constructing the question, and the students answered. I was so happy that almost everybody made correct answers. So your presence encouraged us, the teachers, and when the students become interactive, when the students appear, they want to show that yes, we want to learn. It means the teachers become very much, pragmatic. They try to become very sincere, and they become, very meticulous in teaching in these sessions. So, my dear participants, I hope in the future also in these programs your participation will be a strong one, and so I hope that this type of programs will be in future also from Bangladesh Society of Medicine with your partnership with American College of Physicians. So it's 10 minutes past 10. So thank you very much, everybody. Assalamu alaikum. Good night.
Sadly, we have come to the end of today's program. We have learned so many important things about pictorials from Sir today. I'm sure after today's class, all the students won't worry anymore about the pictorial part of the OSPE examination. Many thanks to the speaker, the chair, the special guest, and last but not the least, the moderator sir for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who asked very important questions. Hope you got your answer. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program on YouTube right after the live session finishes. Our next master class on OSPE will held on 18th of March, where Professor Ahmed Hossain sir will discuss on clinical part of the OSPE examination. I'm pretty sure most of you are eagerly waiting for the topic. So, see you all in the next episode. Until then, take care